Thank you. Very good afternoon. So, INPOC RB 1901 is a prospective collaborative study on retinal blastoma in India. The study is conducted under the aegis of INPOC, which is basically the research wing of Indian Academy of Pediatrics, aimed at conducting collaborative research with the final aim of improving the outcome of childhood cancers in India. And on behalf of the study group, I'm going to present the interim data on time to diagnosis of this study. I don't have any financial interest or any disclosure. Retinal blastoma has the highest cure rate of all malignancies in the world. However, the reported outcomes from India are much inferior in terms of cure, ocular salvage, as well as vision preservation. And we all know that advanced presentation as diagnosis is associated with a suboptimal outcome, and delayed time to diagnosis is one of the major reasons for advanced presentation of the disease. Just to understand the concept of time to diagnosis, there is something known as parent lag time, which is basically the time when the symptom is first noted by the parents and the first consult is taken with the healthcare provider, versus the delay in the healthcare system, which is basically the first contact with the healthcare system and the delay for the diagnosis following the first contact. It is important to understand this concept to be able to address and optimize the delay, and this was the main aim of conducting this study, to see the epidemiological clinical features of retinal blastoma in India and to see the outcome following a standardized treatment strategy. One of the secondary objectives is to understand the reasons for delay in diagnosis, and I'll be presenting the interim analysis data on this point. All centers in India who are treating retinal blastoma were approached to join the study. A study outlines a standardized protocol, and the treatment pathway was laid down. It was peer-reviewed. Epidemiological, clinical, socio-economic treatment and the outcome data were collected, and all the centers got their ethics approval before and starting to enroll the patient. Till now, there are 20 collaborating centers who the study is still enrolling patients, and 1,000 patients has been enrolled till date. As far as the gender, age, and the laterality is concerned, this is at par is what is reported in the literature and in tally with what the global retinal blastoma study tells us. Leukocoria, as expected, was the most common presenting symptoms. If we look at the stage of the disease, stage 0 means the disease is confined to the eye and we are not able to say we are able to save the eye. Anything beyond stage 0, stage 1 onwards is where the eye has to be sacrificed and needs enucleation. So this was at half of the patient in the study presented at stage 1 and beyond. And if we see the data of stage 3 and stage 4, which are basically extraocular and metastatic disease, 1/5 of the patient presented at extraocular or metastatic disease. Just to put it in a pictorial manner, it's a very crowded graph, but shows the geographic distribution of the patient across the country. But if you narrow it down, just to include the stage 3 and stage 4, which are the extraocular and metastatic disease, it seems to be concentrated mostly in the northern belt, northeastern, and some part of the central India. The distance the patient travels for treatment is an indicator of access to care, and about 1/3 of the patient in this study had to travel more than 500 kilometers to avail the treatment. Symptom to diagnosis in half of the patient, the parents seek the first consult within 1 month in just about half of the 50% of the cases almost. In other half, the consult was taken more than half, 1 month, and sometimes more than 9 months also. The first, as expected, the first healthcare provider to be visited was an ophthalmologist, but what was striking was even when the ophthalmologist was the first healthcare provider to be contacted, 38% of the cases the diagnosis was not made at the first consult, and on an average 3 consults were required before the diagnosis could be made. There was a significant correlation of increased time to diagnosis with when the strabismus was the presenting symptoms, when the distance from the treating center was more, low socioeconomic status of the patient, stage of the disease, and there was a negative correlation with improved parental education status. So to conclude, half of the patient in this study did seek the first consult within 1 month of onset of symptoms and were diagnosed within 1 month, but it also means 50% did not seek any consult within 1 month of symptom onset and were diagnosed later than a month or so. 1/5 of the patient were diagnosed at stage 3 and stage 4, where life salvage becomes very difficult. And there appears to be delayed recognition both by the family as well as a delayed diagnosis at the healthcare provider level, including the ophthalmologist. Prolonged time to diagnosis did correlate with the advanced stage at presentation. So what it means that if we have to make efforts to improve the outcome of retinal blastoma in India, it should be directed towards community awareness. Simultaneously, we need to have advocacy initiatives for routine screening of during the contact with any healthcare providers, like the immunization, and the awareness and the training of the healthcare providers, including ophthalmologists, for better awareness and early diagnosis is an absolute must if we have to improve the outcome. We now have very good treatment modalities which is available, but unless and until we pick up the tumor at a stage where the disease is still inside the eye, having advanced treatment modalities is not going to make too much of a difference in the outcome in our setup. Also, half of the patient, even the diagnosis was, if it was established within 1 month, still half of them were stage 1 and beyond, meaning that in half of them the eye could not be salvaged and it was an advanced intraocular disease. So whether there is a more aggressive tumor biology at our setup is something we need to understand and could pave the way for future research in this direction. So I acknowledge the contribution of all the participating centers, the co-PI and the study team, as well as CanKids, who has supported the funding for this study. Thank you for your attention.
Very nice presentation, SIMA, and also the epidemiological study that you have conducted. My one question is, what are the barriers in the time to diagnosis, and what have you done to mitigate the barriers?
Yeah. So one of the reasons this study was conducted was not only to identify those barriers, but also to do some intervention to mitigate those. So what we found was distance was one of the reasons where, even if they were diagnosed, they were referred, they sometimes don't reach the treating center simply because they can't just travel. Financial reasons were there. So that's where the role of non-governmental organizations like CanKids and other come into the picture, where they handle the patient right from the time of diagnosis to ensure that they reach the treatment center on time. And because these patients, we know that they need multiple rounds of travel for completion of the treatment. So that's one. Other treatment modalities, like, even the imaging, something is, so expensive that many families cannot afford it. So the other advanced treatment modalities, if we have to save the eye, like ISC plaque, is something which needs some sort of support. So these are all the barriers which seems to be also playing a factor in improving the outcome, because then those patient gets lost to follow-up. So all these were also addressed as part of the study.
Very nice. Congratulations. It's an eye-opener. Now you should work to mitigate the barriers and help that everyone gets this equal care all over India.
Absolutely.
Congratulations.
Thank you.